Let's now talk about a few different kinds of hypothyroidism. Like I said, the problem is usually at the level of a thyroid, but what's the most common reason for the thyroid to undersynthesize thyroid hormone? Trick question. The most common form found in the United States is Hashimoto's thyroiditis, but in the world, the answer is actually iodine deficiency. Remember, without dietary iodine, you can't make thyroid hormone. But step 1 is mainly concerned with Hashimoto's and other thyroidities, and no, I didn't just make that word up. Look it up. So, we'll be spending most of our time discussing those.
The three thyroidities all have formal names which describe what they actually are, and eponyms which basically means it's named after someone who is ego-tripping on a new discovery. You need to be able to recognize both for the test, though. As I mentioned before, Hashimoto's thyroiditis, or chronic lymphocytic thyroiditis, is the most common form, followed by de Quervain's, or subacute thyroiditis. Bonus points if you pronounce it with an exaggerated French accent. Finally, there's Riedel's, or fibrous thyroiditis. All three cause damage to the thyroid gland in ways suggested by their formal names. Hashimoto's thyroiditis is caused by a chronic autoimmune attack against the thyroid gland's main enzyme, thyroid peroxidase, and against the thyroglobulin itself. This leads to a dense lymphocytic infiltrate. Subacute thyroiditis, on the other hand, often occurs after an upper respiratory viral infection and causes granulomatous inflammation. Unlike the other two, this one is actually quite painful. Remember, de Quervain's brings the pain.
Riedel's thyroiditis is caused by a fibrotic condition known as Ig4-related systemic disease. It causes fibrosis of the thyroid gland that makes the thyroid rock hard and fibrotic. The funny thing about this one is that only about 1/3 of these patients become hypothyroid, but the more serious aspect of this disease is that the fibrosis of the thyroid also causes nearby structures to fibrose as well, which is not great because there are a lot of important structures running through the neck. All three can cause palpable goiter, though that's not always the case.
Riedel's thyroiditis can cause slow, progressive hypothyroidism, but the other two often cause such aggressive destruction of the gland that they basically rupture all the follicles and release all the stored thyroid hormone at once. Now this can cause transient hyperthyroidism that soon gives way to hypothyroidism once the excess hormone is cleared and the thyroid gland can't make anymore. But here's the big difference. Hashimoto's thyroiditis keeps getting worse and worse until the whole gland's completely atrophied, whereas subacute thyroiditis will get better over a period of months. A couple more words about Hashimoto's thyroiditis, because this is the one that comes up most often. Now the histology is kind of interesting because it's not just lymphocytic infiltration. You've actually got legit germinal centers in here as well, like right here and right here. As well as something called Hürthle cells, which you seriously just have to remember by name. Now, whether or not this is related, people who develop Hashimoto's thyroiditis have a significantly increased risk of developing non-Hodgkin's lymphoma. Final bit of trivia, it's associated with the HLA-DR5 antigen. Anyone know which other disease is associated with that specific MHC molecule? The answer is pernicious anemia. You can review the HLA antigens in the immunology section of First Aid. They're a serious pain to remember, but seriously don't put it off. Just flashcard it consistently and you'll get it after a while.
Compared to iodine deficiency in the three thyroidities, the other causes of hypothyroidism are pretty low yield. In the developed world, it's important to remember that certain drugs can cause hypothyroidism. Can you remember the two big ones? This might be a little bit of a mental exercise, but you should remember that both the antiarrhythmic amiodarone and the mood stabilizer lithium can cause hypothyroidism. But the last kind of hypothyroidism I want to talk about is congenital hypothyroidism, also known as cretinism by, well, mean people. Like with most kinds of hypothyroidism, congenital hypothyroidism is most often caused by maternal iodine deficiency worldwide. In the US, however, it's most commonly caused by a fetal thyroid abnormality. Do you know the mnemonic for the symptoms of congenital hypothyroidism? Well, before you hit up the mnemonic, you have to know the two most apparent symptoms at birth, hypotonia and jaundice. The mnemonic 6 Ps refers to the constellation of symptoms present with very severe hypothyroidism. Pot-bellied with a protruding umbilicus and a protruding tongue. They're also pale and puffy-faced, with most importantly, poor brain development. They may not present with all these symptoms immediately, but if thyroid hormone isn't screened for example in a developing country, they may continue to develop these symptoms over a period of months. Well, that wraps it up for hypothyroidism. We're going to move on to types of hyperthyroidism, but first, let's do a flash quiz.
Alright everyone, it's time to play Name That Disease. Name the disease process that leads to granulomatous inflammation of the thyroid gland. The answer is de Quervain's or subacute thyroiditis. Remember, the clinical pearls for this disease are granulomatous inflammation, painful, and it gets better. Hyperthyroidism has fewer causes than hypothyroidism, and the most important one by far is Graves' disease. Graves' disease, like Hashimoto's thyroiditis, is also autoimmune, but these antibodies are specific to the TSH receptor. Now the wacky thing is, these antibodies don't destroy the thyroid gland, they're actually close enough mimics of TSH to be recognized by the receptor and stimulate the synthesis of thyroglobulin and thyroid hormone. So the whole gland gets diffusely enlarged and starts hypersecreting T3 and T4. Now here's where things get really crazy. The Graves' autoantibodies can also target certain pockets of connective tissue, specifically the extraocular muscles and the skin that directly overlies the shins. They go on to induce mucinous deposition, much like you'd see in hypothyroidism, but by a totally different mechanism. Myxedema of the shins is known as pretibial myxedema, and it's worth noting that this is a non-pitting edema, meaning that if you poke the skin, it doesn't leave an imprint like a Tempur-Pedic mattress. The deposition in the extraocular muscles leads to the most noticeable symptom of Graves' disease, exophthalmos. Literally, the extraocular muscles get so buff that they push your eyeball straight out of your socket until you look like this. Exophthalmos is an extremely high-yield buzzword for Graves' disease, but you have to remember, the exophthalmos is not a symptom of hyperthyroidism. It's a completely separate disease process that's related to the Graves' autoantibodies. Last couple things about Graves' disease. It shares more in common with Hashimoto's thyroiditis than you might think. For starters, they're both autoimmune, so which population do they preferentially target? The answer is women, especially in young to middle age. What's more, because autoimmune disease as a category is prone to genetic predisposition, having a family member with Hashimoto's can put you at risk for developing Graves, and vice versa. Finally, Graves' disease can present at any time, but it shows a slight tendency to pop up during times of stress. Now, Graves can be treated either medically or surgically, which we'll go over in a moment, but it's not usually an emergency. When stuff gets really out of hand is when you've got a patient whose thyroid levels are inadequately managed that at the same time hits a period of illness or high stress. Then you get the ICU version of hyperthyroidism called thyroid storm. Since thyroid hormone is responsible for increasing metabolism, what physical finding are you definitely going to see in these patients? High fever, right? But the really lethal consequences come from the fact that T3 and T4 increase the body's sensitivity to beta-adrenergic stimulation, basically giving you a sympathetic overload. Now how's this different to what you'd see in a pheochromocytoma patient? Remember, pheos actually increase the catecholamine synthesis, which will go on to hit both the alpha and beta-adrenergic receptors. And thyroid hormone? That actually only increases beta-adrenergic sensitivity, so you're actually not going to see hypertension. What the beta receptors do affect is the heart, and in thyroid storm, that ends up being the most lethal consequence, tachyarrhythmias from excess sympathetic stimulation. So the problem is sympathetic activity, and what's your treatment going to be for that? The first drug you use in thyroid storm is propranolol. The beta blocker will give your heart a little bit of a break after all it's been through. Now the next thing you want to do is address the thyroid issue itself with propylthiouracil, an antithyroid drug that can be used for either maintaining thyroid suppression long-term or bridging the patient until they can get their thyroid removed. Finally, prednisone is used to decrease the peripheral conversion from T4 to the more active T3, a cool effect of prednisone that you definitely don't need to memorize. So, if you see a guy with heat intolerance and weight loss who looks like Igor from Young Frankenstein, you can be pretty sure it's Graves' disease, right? Sure you can. But what if the patient doesn't have exophthalmos? It could be a number of other things, and the most important alternate cause of hypothyroidism that you need to know is the toxic thyroid adenoma. Unlike Graves' disease, which is diffusely enlarged on palpation, a thyroid adenoma can often be felt as a palpable lump on the thyroid. And as we mentioned, thyroid adenomas are never associated with exophthalmos or pretibial edema, whereas Graves' disease often is. Finally, the thyroid gland is often assessed by the level of radioactive iodine uptake, a method called thyroid scintigraphy. While Graves' disease will show diffusely increased uptake, a toxic thyroid adenoma will show up as a focal increase in uptake, colloquially known as a hot nodule. If there are multiple focal adenomas, then you call that a toxic multinodular goiter. Now, radioactive iodine scanning is kind of awesome because it's useful for other stuff as well. For example, what if the patient had all the symptoms of hyperthyroidism, but his thyroid had pretty much no uptake? Now, one likely explanation is that he's actually in the early stages of either Hashimoto's or subacute thyroiditis. Remember, at that point, they were releasing all their stored thyroid hormone, but the inflamed thyroid's too sick to suck up iodine and synthesize more. Another reason is that they're taking exogenous thyroid hormone. Either they're accidentally taking too high a dose of levothyroxine for their hypothyroidism, or they're abusing thyroid hormone to lose weight. Both of these will feedback suppress the thyroid gland to diminish endogenous production while causing the symptoms of hyperthyroidism. But on another note, what can a thyroid lump mean besides a reasonably harmless adenoma? You got it, cancer. As is often the case with endocrine tumors, though, the actually malignant cells are often so far mutated that they're not really very good at producing the hormone anymore. So, if you see a scan like this one, you can feel pretty good about that, because a hot nodule is a working nodule, and in the thyroid gland, that almost always means that it's not malignant. A cold nodule, one that doesn't take up the tracer, is a lot more worrisome. On that note, let's take a look at some of the thyroid cancers. So the most common type of thyroid cancer is papillary thyroid carcinoma, which, fortunately enough, has an excellent prognosis. It can be associated with childhood radiation exposure, and if it spreads, it tends to do so via the lymphatics. And while that's pretty good to know, the most likely thing you'll have to know about this cancer is the histologic appearance. First of all, it's called papillary cancer, so what does that tell you about the histologic appearance? Well, papilla means nipple, so it's obviously named by a male pathologist that's clearly never seen a nipple in his life. Here's the nipple outline that I think they're talking about, though I would probably call it a finger-like projection. The other buzzword you hear all the time is orphan Annie eyes, which, in case you weren't born in the 1950s, looks like this. Apparently they thought this was cute, even though I think she needs an exorcism. Anyway, you can see one of those eyes right at the tip of the papilla, where you'll note the soulless emptiness inside the nucleus that's reminiscent of Little Orphan Annie. Finally, papillary thyroid carcinoma is only one of a handful of cancers that can have samoma bodies visualized on the slide. You remember the mnemonic for those cancers? It's SAM, or papillary thyroid cancer, serous cystadenoma, or adenocarcinoma, meningioma, and malignant mesothelioma. And a samoma body is basically what happens when one of those nipple-like projections gets circumferentially calcified and is visualized on cross-section. They look a little something like this. Medullary thyroid carcinoma is the other one you need to know a little bit better than the average. It's a thyroid cancer of the parafollicular cells, and it secretes calcitonin. But possibly the most important thing about it is the association with the very famous multiple endocrine neoplasias. We'll get to them soon, I promise. Unfortunately, these ones have a poor prognosis, and actually, high-risk MEN patients often get their thyroids removed prophylactically. That's how risky it is. On a slide, it looks a little bit like this, and you'll see that unlike papillary carcinoma, it's got nice shiny chunks of amyloid floating around in it. Other than those two, the amount you have to know about the others is pretty minimal. First off is thyroid lymphoma, which we talked about like a second ago. Which other thyroid condition is this associated with? It's associated with Hashimoto's thyroiditis. Then there's follicular carcinoma, another one with a good prognosis, which is unique because it's arranged into nice, neat follicles, just like regular thyroid tissue. None of this nipple nonsense going on. It's unique because it tends to spread hematogenously. Finally, there's anaplastic carcinoma of the thyroid gland, and does that sound like a good cancer or a bad cancer to you? Here's a hint. The word anaplastic is never a good thing in oncology. That means the cancer is so far mutated that it bears pretty much no resemblance to the original tissue. This one tends to happen in older patients, is locally invasive, and has a terrible prognosis. So, I save the discussion of treatment for last because this sort of encompasses both hyperthyroidism and thyroid cancer. In the broadest sense, the preferred treatment goals are the same. You get rid of the thyroid. So how do you do that? Well, you can always cut it out, as your helpful friend the surgeon might suggest, Or you could use radioactive iodine, which sounds scary, but is actually one of the most well-tolerated radioactive treatments. The reason is because iodine is thousands of times more concentrated in the thyroid than anywhere else. So only the thyroid gland gets nuked. If you go this route, though, the patient's going to need supplementary thyroid hormone afterwards. The other option is to take the antithyroid drugs methimazole and propylthiouracil, either long-term or just long enough to suppress the thyroid before getting rid of it. Now, all three of these options are used in hyperthyroidism. Though patients who are on antithyroid meds for long enough generally get the gland removed. For most thyroid cancers, the answer is going to be surgery, though radioiodine ablation can be used as an adjunctive therapy to nuke the little microscopic chunklets that are left behind. Let's talk a little bit more about thyroidectomies, though, because while they're the mainstay of treating thyroid pathology, there's a couple of very high-yield complications of this procedure. What are some of the important structures that run near the thyroid that you know could be damaged during this procedure? Probably the highest yield ones are the recurrent laryngeal nerves, which ascend from the thorax to innervate the muscles of the larynx. Cutting one of these causes paralysis of one of the vocal folds, and causes sort of a breathy Marilyn Monroe voice and an inability to cough, since the vocal cords don't seal nicely against each other. You'd have to be pretty unlucky to get both of them cut, but if you do, that's bad news bears. Because if both of the vocal cords get paralyzed while pressed up against each other, you've essentially just sealed off their airway with no way for them to open it back up. And if you're unable to get an endotracheal tube down there, then you may very well have to cut their neck open and create your own airway. There's also the possibility of superior laryngeal nerve damage during a thyroidectomy, but this isn't as high yield. Now, what's another fun structure that sits directly on the thyroid itself? Parathyroids, of course. And what electrolyte abnormalities would parathyroid damage cause? If parathyroid hormone causes increased calcium at the expense of phosphate, then accidental removal of the parathyroids during a thyroid removal will cause decreased calcium and increased phosphate. And that about covers it for the thyroid gland. Let's wrap this up with a flash quiz. Here's one that covers the gamut of thyroid disorders. A patient complains of increased appetite, weight loss, increased sweating, palpitations, diarrhea, and heat intolerance. Name 3 thyroid diseases that could possibly cause these symptoms, and identify which is the most likely diagnosis. Pause the video, take your time with this one, and when you're ready, I'll have the answer for you. So, this patient is presenting with clinical hyperthyroidism. The most common cause is Graves' disease, but a toxic multinodular goiter is also a cause of hyperthyroidism. Thyroid malignancies don't usually secrete thyroid hormone. They're cold nodules, remember? The Jode-Basedow phenomenon, which most of you I'm sure already forgot, is another reason for someone to become hyperthyroid. That's where someone who's been iodine deficient for a while grows a huge hyper-functioning goiter, so that when they finally get the iodine they need, their megathyroid cranks out way too much thyroid hormone before it eventually learns to shrink down a bit. Finally, remember that the inflammatory thyroidities, Hashimoto's and de Quervain's thyroiditis, can present with hyperthyroidism early in the course of the disease. Riedel's thyroiditis, however, does not. Now that's it for the thyroid gland. Now we're going to take a quick trip to the dark side of the thyroid gland and explore some of the pathologies of the parathyroids.